working in ZEISS Military Hospital, and currently I am the President of United Optometrists Forum. Today I welcome everyone to this beautiful webinar where we are going to discuss about refractive error. This will be a series of webinars where today we are going to introduce the first part, that named as Foundation of Refractive Error Assessment and its Management. And we have eminent speakers from throughout the world. So what we are waiting for? Currently I am standing in UAE studio. I am referring to the UK studio, our colleague Jabin Jafar, who is going to introduce the first speaker of this evening. Over to you, Ms. Jabin.
Thank you, Mr. Swarna. Good evening, everyone. My name is Jabin Mohammed Jafar. I am an optometrist at Medcare Eye Center and a member of United Optometrists Forum. Our first speaker is from the land of world's oldest eye hospital. I'd like to call Dr. Alex Manoska, who is an associate professor of University of Brampton, UK. She will be talking about fundamentals of refractive error. Over to you, Dr. Alex.
Good evening, and thank you to ZEISS for the invitation to join you in this webinar tonight. If you just allow me to share my screen, I will bring up my presentation. Okay, so my name is Alex Mankowska, and I'm a lecturer and an optometrist, and I work at the School of Optometry and Vision Science at the University of Bradford in the United Kingdom. I'm the clinical lead for binocular vision and reading, and I also see patients, mainly children, with learning disabilities and special educational needs, and we regularly test these children in their location within the school. So just to confirm that I have no financial interest in participating in this webinar this evening. So the subject of refractive error management is central to our profession, and we should explore this topic on a regular basis to both refresh our knowledge and to remind ourselves of its importance. My role in tonight's webinar is to give you an overview of the etiology and prevalence of refractive error, to discuss briefly assessment, detection and assessment, and to look at the impact of uncorrected refractive error on our patients and what we as eye healthcare professionals can do to help in the education of our patients and also those around us who can advocate for more eye healthcare work to be done in all our communities. In most cases, refractive error may be treated or corrected with either glasses or with contact lenses. A study in Germany from 2011 found that 21% of visits to the ophthalmologists were related to refraction problems. In the United Kingdom, our National Health Service estimates that over 13 million sight tests are performed annually. It is what we call our bread and butter. Any investigation of any eye condition should start with a measure of how well the patient can see. And usually the most common reason for reduction in vision will be refractive error. From a pure perspective of visual optics, refractive error develops as a result of the relationship between the components of the optical system. The radius of the cornea, the depth of the anterior chamber, the thickness of the crystalline lens, and the axial length of the eye. For pre-presbyopes, this may result in either spherical forms of ametropia or astigmatism. And when the crystalline lens begins to lose its elasticity, this is when presbyopia develops. For each type of ametropia, myopia, hyperopia, and astigmatism, we understand how the relationship between the optical components has altered to produce the defect. In the case of spherical ametropia, it is the relationship between the axial length of the eye and the refractive power of the eye, which makes the eye either myopic or hyperopic. In the astigmatic eye, it is the deformation of the corneal curvature, or perhaps of the crystalline lens, or maybe even both, that will cause the refractive defect. And as we know, in the 5th decade of life, the eye's ability to see objects at close working distances reduces because of a marked decrease in the amplitude of accommodation. Now, presbyopia means old sight, but I would not advise you to be telling this to an anxious patient. Presbyopia is defined as the eye having only 3 diopters of accommodation left. But we know that patients usually have more around about the time when they begin to develop the first symptoms of presbyopia, perhaps 5 diopters of accommodation. Where problems occur is usually because patients have to work at closer working distances, perhaps for longer periods or in poor light, and this sustained effort becomes too much for them, and that's when they first begin to notice the symptoms. But as eye care professionals, we cannot consider refractive error development purely from a term of pure optics. We have to recognise that human refraction develops over time, from childhood right through to adulthood. So we must consider the optical changes that occur in the context of emmetropization. Our understanding of emmetropization has been that from birth, the optical components of the eye will change and develop so that by the age of 6, the eye has become more or less emmetropic. We know that this is modulated mainly by the change in axial length of the eye. The graph produced here from the Flitcroft paper written in 2014 is a combination of graphs from two renowned researchers who show us the expected distribution of refractive error once emmetropization has been completed. These figures give us an indication of the distribution of refractive error of refraction from 3 months right through to 3.5 years. As we can see from these 2 graphs, there is a significant shift that occurs in the early years in the mean refraction, from approximately +2 diopters to around +0.75, which is where we end up down here. Secondly, we also notice the change that the standard deviation, or the spread of refractive error, has significantly narrowed over this amount of time. And we can see that anybody who remains outside of this normal distribution is a hyperope, and they will remain a hyperope throughout life. It could be said that emmetropization has almost totally or nearly failed for these patients. So it is right that in these early years, the focus of our clinical work for this age group is to identify those children with hyperopia. Our principal concern for them has been to avoid amblyopia and anisometropia. But after the age of 6, we notice that refractive error development shifts towards myopia. And there are many studies that are coming out from all over the world that are showing the increasing prevalence of myopia amongst teenagers, but also amongst adults. Here, again, from the Flitcroft paper, we have 3 representative studies from different parts of the world that show the distribution of refractive error amongst teenagers. We can see that the distribution is slightly different in different parts of the world. So there is a slight difference between teenagers in Australia to Northern Ireland to Japan, where the shift is more towards myopia than it is considered to be in Northern Ireland. We know that at this point, there is also a greater influence of environmental factors, for example, long hours of study, that would contribute to the development of myopia by promoting axial length. We can also see changes in adults. Here is a graph of an adult population from Japan. And again, we can see whilst the distribution remains around the emetropic mark around plano, there are a higher number of participants who were seen to have more myopic prescriptions than we may have expected several years ago. So from this we can conclude that it is no longer really possible to say that emetropization stops at the age of 6. Flitcroft suggests in his paper that myopia development in later life is due to a secondary failure of the emetropization mechanisms that maintain emetropia or low hyperopia. So why is this important? Well, again, along with all the work that has come out in recent years, there has been a lot of data to support the need to address the issue of uncorrected refractive error, not just myopia, but also presbyopia, and generally all the defects of ametropia that we are familiar with. You can see from this table that we are talking about the effect not just in terms of productivity, but it is the numbers turn into billions of people who are affected. If we look at a study from the Middle East, which was carried out in 2020, this is a meta-analysis that was produced by Kaushal et al. And this study was very interesting because it highlighted the diversity of ethnicity and racial groups within the region. Having looked at a total of 47 studies, the authors concluded that actually the overall prevalence of refractive errors was what they classed as mid-range compared to other parts of the world. So there is neither a increased number of myopic or hyperopic patients that we see within the Middle East. They also concluded that the amount of astigmatism that is seen does not present really to be a significant problem. But what we can see from here is that there are equal numbers of hyperopes amongst male and female participants in the various studies, and that also there is an increased number of myopes later on in life compared to younger participants. I would also like to share some data from a study that was carried out with our friend and colleague, Dr. Yazan Gamo, who is also on this panel. This study was carried out between 2022 and 2023 with a colleague from Bradford, Professor Brendan Barrett, and we collaborated with Yazan to carry out a study on the detection of hyperopia in school children in Jordan. Over 1,200 children were sampled between the ages of 6 and 14. We are still working on the data, but we can share a first look at some of the prevalence data with you this evening. And again, looking at some of the previous studies that have come out, we can see that overall, the general distribution, so this is, if we look at the graph that appears on the left-hand side, the top graph is spherical equivalent for the right eye, and the bottom graph spherical equivalent for the left eye. We can see that there is a general distribution in this age group around emetropia and low hyperopia for both the right and the left eye. And this seems to actually hold out when we break the participants down by age groups that relate to school stages. But if we have a look at our comparison of refractive error and axial length, we can see that there are some interesting shifts in the children as they get older. So perhaps we don't see a development in their refractive error, but we can actually see that there is still growth in the axial length of the eye, which may or may not be a predictor for for a myopic shift in refractive error in later years. So it is interesting to have a look at this data from a number of different aspects, and that's what we're still doing. So let's look at the ways in which we can identify refractive error. And I'm sure that looking at this table, there are no surprises to you on here. How do we do it? Well, first of all, the patient must report this, must recognize that they have symptoms that are causing them discomfort and that they are related to their vision. And probably the ones that I have listed here are the most common presentations. I'm sure that some of you will also recognize that there are patients who attend at specific times of year. So perhaps when we alter seasons, when lighting conditions change, when there is a change in their circumstance, and this may bring them to our practices more readily than at other times. There are many questions about the hereditary nature or the genetic nature of certain types of refractive error. The estimates, for example, I have seen studies where the estimates of the genetic or hereditary nature of myopia range between 50 to 90%. And I think we still need to look at those measures. Amblyopia generally per se, there is no clear genetic link because we have to look at the reasons why the child is amblyopic. So is it due to strabismus? Is it due to anisometropia or other forms of refractive error? And those are probably the underlying reasons that may or may not be hereditary. And finally, when the patient is sitting in our chair, of course, the measure of their vision, and I would advocate looking at both distance and near, monocularly and binocularly, will allow us to determine whether or not a patient really does have a problem with their refraction that has to be addressed. And I believe that these should be routinely measured in all our patients if it is possible. Again, if we think about assessment techniques, I don't think that there are any surprises here. Thinking first of all about our objective techniques, for most of us, the most important skill that we learn when we are training to become optometrists, ophthalmologists, is retinoscopy, because this allows us to see objectively how to try and estimate objectively the patient's refractive error. We have probably become more reliant on autorefractors because they allow us to increase the throughput of our patients. And we know that autorefractors have become more accurate in terms of providing us with a good estimation of refractive error. But I think that using our own skill is probably should be the final arbiter of a patient's refraction. If we think about subjective refraction techniques, well, there are two sides to this coin, because here we rely on the patient's input, so that allows them to tell us how their vision is responding to the changes that we are proposing. But we know that this can be a timely process. But we must not overlook the other factors that would also influence the final refractive error correction that we give to our patient. So, as we've mentioned before, measures of visual acuity, but also an examination of the ocular structures, which may be done with a variety of techniques. We must consider the patient's accommodation if we're dealing with pre-presbyopic patients, and also, and I would advocate this very strongly, the binocular visual function of the patient, as these are all very important. I wonder how many of you have seen a gimbal scope. I must admit, this is the first time that I came across it when I was looking at this. It's described as a digital retinoscope, which incorporates the use of a smartphone with our retinoscope. But ultimately, it still requires us to be able to carry out retinoscopy correctly. I think that this is to be used more as a teaching tool, but I just thought I'd show you this out of interest. And whilst we're talking about refractive error assessment techniques, I think we must also consider the importance of the use of cycloplegia, in particular in our younger patients. And here I'm returning to our data from Jordan. We had one of the ways in which we had a look at the data was looking at the refractive error group that the children started off in when we took measures on the autorefractor before cycloplegia, and once we had instilled cyclopentolate. And we found that if you started as an emmetrope, you weren't necessarily an emmetrope when we looked at you under cycloplegia. In fact, 80% of our participants started to show a hyperopic prescription when they started out as an emmetrope once we had the cycloplegia. And also, if you look at the myopes in our study, again, a significant portion of them shifted into the emmetropic refractive group once we had introduced a cycloplegic drop into their eye. So I think this just shows the importance, this emphasizes the importance of considering the patient's prescription, both with and without cycloplegia, especially if we are not very sure that they have been reliable in their subjective refraction. Just thinking finally about the impact of uncorrected refractive error. As I said before, there are many studies now coming out that are showing us the impact of uncorrected refractive error on patients worldwide. Of course, a lot of this will be in countries where there is limited access to eye healthcare professionals, but not just in those countries. These problems affect both patients all over the world. And we see that the effect of this is not just on the patient themselves in terms of what they can see, but also how they can be involved in good productive work. We see that there is an increase in the loss of productivity and also of jobs if a patient perhaps is unable to attend work. Much earlier than that, we can see the effect of uncorrected refractive error, particular hyperopia, on children in terms of their ability to perform well at school. And this is becoming more and more studied in many countries. And in later life, we can see the effect of a patient who may be isolated because they don't feel confident enough to go outside, and there is an increased risk of falls, of depression, of isolation for our older population. What can we do about it? First of all, make sure that we provide good access to healthcare, both in terms of full eye examinations for our patients, but also in terms of screening programs for both young and adult patients. We should also be prepared to advocate for resources within our local communities, wherever that may be, whether that is through our professional bodies, through our local hospitals, or through any government agencies if we have access to those. And finally, we have to think about the importance of educating our patients of the need to attend for regular eye care examinations and for the importance of wearing their refractive correction. To this end, the World Health Organization earlier this year launched a program called SPECS 2030, which underlines the importance of trying to ensure that we can improve access to eye healthcare and refractive correction across the world. The target that has been set by the organisation is to increase coverage by 40% by 2030. So we can see from this that it is a problem that affects all of us, and we should all be playing our part to do whatever we can to help our patients. Thank you.
Thank you, Dr. Alex. That was a wonderful talk. Now we move on to our next talk from Qatar studio. Over to you, Mr. Swarna Kamal.
Thank you, Ms. Javin. Dear colleagues, how we can forget about 2022 Football World Cup and the nation which made it tremendous success? Yes, I am in Qatar studio and I would like to call the speaker from Qatar, Dr. Pedro Matar, who is a senior pediatric ophthalmologist from Sidra Hospital, Qatar, and who will be talking on consideration in refractive error and its management. Over to you, Dr. Pedro.
Hello. You think? Yes. Can you see the slides? Yes? Okay. Well, my name is Pedro Matar. I'm very honored for the invitation by ZEISS. I just want to tell you something. I've been very lucky. I am a pediatric ophthalmology, and during my career, my formation, and all the years that I've been practicing, I always have been working together with the optometrist. So I think for a good practice, you need to work together with the optometrist. Today, I'm going to talk to you about what I do the most is to see children. And I'm going to talk about some considerations about glasses prescription in children. Okay. Nowadays, I work in Qatar, in Sidra, that's your home. And I work with two excellent optometrists, Dr. Angela Malik and Dr. Maria Yesa Chavez. They're wonderful. And nowadays, I have the opportunity to work also with orthoptics. And with all of us, we're trying to do our best for our children. So I don't have any financial relationship with commercial interest to disclose, even though you might see some brands in glasses or different things, but I don't have anything to do with that or any relation or financial relationship with that. All of the photographs that you see here, most of them are taking of our patients. Their parents have been consented to do it, so please do not use these pictures in any other presentations or don't take videos about these children. I always start with this, with a slide like this, even if I talk about cataracts, if I talk about different topics in children. And we have to remember that, let me put the timer because I'm very bad with this. Yes, okay. We have to remember that the children's eye is not a small eye of an adult. It's an eye that is in constant growth. It has a time of plasticity that we don't know yet until when is the plasticity. When I started ophthalmology, they said that 7, now 15, now 18. Now, even though some adults, when they have a trauma in the eye that they used to see and they had the other eye that it was amblyopic, they start to see from the other eye. So until when is the plasticity of the human being in his visual system and in his eyes? It's an eye that the inflammation affects the eye in totally different way, and it can be amblyope. It can be harm in a way that even if you have a healthy eye, if you don't get the right information focusing and into the brain, you can develop amblyopia. So Dr. Alex already talked about epidemiology. I just want to say something. The refractive error is the most common cause of reduced vision in children, affecting between 2 to 11% of the population before 16 years of age. And it's also the responsible of the 60 to 80% of the visual impairment in children. And that's something that we need to know. There are different publications that talk about which is the prevalence of amblyopia in preschool children. I used to tell to all of my pupils that imagine you're going to classroom of 40 children. You have to think that at least 4 of them, they might have an important problem in the eye and they can have amblyopia. So Dr. Alex also talked about the metropization. She presented a lot of publications and very important ones. So I just want for you to remember that, yes, there is an elongation of the eye. There is a flattening of the cornea that is happening. There is a flattening of the lens, but there is also very important, the visual experience that every patient is having. And there is always also important, the genetic predisposition of each one of our patients. The prevalence of refractive errors, it was demonstrated also by Dr. Alex in different papers. And I just have this old papers, but I think it's very interesting. One is from Brazil, and it tells about the incidence of hyperopia, astigmatism, and myopia in scholar children. The other one is from Saudi Arabia. And you can see how different could be the incidence of different refractive errors depending about the area where you're coming from, where you were born, and where you have been raised. I love this paper. This was a very old paper from 1912, done by Dr. Alexander Duane. All of us, we know what is the Duane, it's coming from him. And he demonstrates which is the amplitude of accommodation depending about the age of the child. So until on the first, the newborn can have a 14 diopters of possibility of accommodation. An 8-year-old can accommodate up to 14 diopter minus plus 2. And that will decrease 1 diopter for each 4 years of age until we're about 40 years of age. And all of us that we are, in my case, more than 40 years past, we need glasses to see at near because we don't have the accommodation anymore. So about glasses in children, we have to take in consideration when we're going to prescribe glasses for them, the age of the patient, the individual visual needs that they have. We have to know that even that we're going to present some tables, there is not a strict nor exact rule about what do we need to correct in each patient. We have to individualize the patient. And in children, we have to have a baseline. We always have to have a cycloplegic refraction. Dr. Duane demonstrated many years ago that they can accommodate. They can fool even the new machines. And it is very important always to do the right cycloplegia. Which protocol would you like to use? There are several protocols out there. This is the one that we use in our practice. In children that preterm to 3 months, normally we always use the first drop. We try to use an anesthetic. It can be oxybuprocaine or it can be proparcaine. What do you want is that this drop will break the barrier of the epithelial cells, some of the barrier of the epithelial cells that the cornea has, and will let the drops to go into the eye in a better way. We use the cyclomadril, that is the combination with cyclopentolar and phenyl, and we can add also tropicamide 0.5% in children when they're less than 3 months. 3 to 12 months of age, we like to use cyclopentolate 0.5 with phenylephrine 2.5, and we use also, and we can add tropicamide as well. It is important when you put drops in children, and what we're going to talk, it's about some of the tips that they have been very helpful for me in different moments in my life. But what is important is not to clean after you put the drops of the eyelashes, because some of these drops, they will absorb again. And in patients, when they're more than 1 year of age, we use cyclopentolate 1%, phenylephrine 2.5, or tropicamide. Normally, we don't use atropine as a protocol for cycloplegia in our patients. It is important to know that phenylephrine is contraindicated in patients when they have heart conditions or they have hypertension. We have to use the cyclopentolate with precaution in patients when they have seizures. It has been published that they can induce seizures, but these publications were when we used to use the cyclopentolate 2%. Nowadays, we use the 1% and the 0.5%, but even though we have to be careful in this. And for all of us that we're doing cyclorefraction, I think it is important to have the physostigmine in the office, or to have a pediatrician close to you in case that you will need to inject a patient because they're having a problem because of the cyclopentolate. Remember that the high ametropias can be related with problems with associated syndromes or abnormalities in the eyes of the patient, and that's something that we always have to take in consideration as well. When do we know that a patient has a good cycloplegia? It's not only, or we don't talk only about if the pupil is big or not. We need to know if it is paralyzed, the focusing of the eye of this patient. So when do we use the static retinoscopy? We use a static retinoscopy in those patients that they're aphakic, that they're pseudophakic, or in those that we know that they have a good cycloplegic, a glue cycloplegia. How do we know if they have a good cycloplegia? Well, we can do the dynamic retinoscopy and we ask the patient to look at far. Then we pass the strike into the eye. We see the size of the strike, which is the reflex, and then we move ourselves in the center of the vision of the patient and we ask them to look at us and to do the same thing. If the strike maintains the same size and it doesn't change, most likely, the patient will have a good cycloplegia, okay? So try to avoid when you're doing the test at far to get into the center and in the middle, because if not, the patient will be looking at you. About the autorefraction. Nowadays, we have a handheld autorefractors. We have several type of autorefractors. There are offices that we don't have the handheld and we have to use the one that is on the stand. It is very, very important when we use a stand autorefractor for the child to have his forehead close to the machine. If the forehead is not close to the machine and it's apart, it will estimate a refractive error that is totally different. Here down, you will see one of the different papers that we can have for an autorefractor. So which is a good measurement? You will see that the measurements are always the same, that the axis of the astigmatism is more or less the same, and that can give us an idea that the measure that it was taken by the autorefractor was accurate. About guidelines for refractive correction in infants. There are several publications out there. I would like to share with you the one that I use. Is the one from the American Academy of Ophthalmology, the preferred practice pattern, the guidelines in amblyopia for San Francisco, California, and about the examination in children. If you want to scan the barcode downstairs, you will get the paper that it's free online in the American Academy of Ophthalmology guidelines. And we're gonna go through this a little more in depth. We need to know how to control these patients when they have high ametropia. So we will do it twice a year in patients when they are until 4 years of age. And we're gonna do it once a year in patients that they are 4 years or more. We're talking about patients that do not have an association of strabismus or they don't have any other important problem in the eyes. Notes about hyperopia. In the case of bilateral refractive amblyopia, we always recommend in patients that they have more than 5 diopters of hyperopia of cycloplegia to prescribe the complete refraction or reduce it by 1 or maximum by 2 diopters. In always patients, in all these patients that they have isotropia, we always prescribe the complete cyclorefraction. And in those patients that they have asthenopic symptoms that they come, as Dr. Alex talked before, with headaches, the headaches that they will have are gonna be headaches that you have to ask about when they happen. Normally, the headaches that is related with the asthenopia is a headache that you have it in the frontal part of the head, that normally the patient never wake up with the headache, or he never wake up in the middle of the night because of a headache. And normally they happen at mid-morning or mid-afternoon, and they're related with visual activities or school activities. In those patients, if they have a cycloplegia more than 3 diopters, normally we reduce 1 or 2, so we leave them some of the accommodation. So in those patients, in those patients that they're infants, how do we prescribe these children? So if we have a complete normal ocular examination and the patient has less than 6 diopter of hyperopia, normally we don't do anything, okay? And in those that they have more than 6, normally we prescribe 2 diopters less than the full cyclorefraction. And we add the astigmatic correction in cases that the patient has more than 1 diopter. In case of myopia, and they have a normal ocular examination, In 1 year, we can say it's normal up to 5, and in 2 years, that up to 3 is normal as well. In astigmatism, in the patient is an infant, we don't correct it unless there is more than 3 diopters. In case of anisometropia, the difference between one eye and the other one, if there is a difference of hyperopia of 2 or more, we have to always correct it. In case of myopia, we have to correct if there is a difference of 3. And in case of astigmatism, in case of there is a difference of 2. So this is an example of a child that has this cycloplegia. We don't do anything. In the patient that has 12 diopters, we will try to correct 10. Okay, we're talking about children with normal ocular examination. In those cases of the preschool children, it's a little different. These are the guidelines that we do. We say that 4 diopters or less is normal. And we can say that 2 diopters could be normal, but this varies. This varies, and that's why you need to individualize this patient. There are some patients that they're very curious, and they have an activity that they like to look at far, and they start to do a squeezing. So those patients, I think they need to be corrected. And in case of astigmatism, 2 diopters. In anisometropia, these are the guidelines that we use. So this is an example of a child that has isotropia, so we correct fully. And in case of a patient that is a scholar and has more than 6 years, we more or less treat him just exactly the same like an adult. So this is the guidelines that we use. I give you here an example of an scholar. How much will we correct it? We will correct it 2 diopter less of the complete ephemeral refraction. We have an example here of a 6-year-old boy that have an upper lid ptosis that induce astigmatism. This is a full cyclorefraction. This is what we'll recommend to correct it. What do we do in cases of aphakia or pseudophakia? In those cases, these patients, they will need an AT. Normally in patients, when they're less than 3 years of age, we give an AT of a plus 250 in the monofocal lenses. In those patients that they're 3 years or older, we normally recommend bifocals or progressive in the case of pseudophakics. And in the case of patients that has an accommodative isotropia with high CAA ratio, in those cases, we will use the bifocals. I want to share with you this beautiful, beautiful letter that Dr. Kushner used to send to the opticians and optometrists when he sent a child to do a bifocals. It's a very complete one. You can find it in the internet as well. And at the end, he said something. He explains where it should be the top edge of the bifocal segment. It bisect the pupil. It can be at the bottom. It can be at the level of the lower lid. Yeah, and explain the type of frames, explain everything there. And at the end, he said, if you're unable to provide a frame which approximates the above criteria, please do not dispense. At the end, if an optical shop, they don't have it, they shouldn't be pushing for the child to use it. The compliance depends about several things. First, the compliance of glasses depends about the patient, about if there is a syndrome associated of a pathology. Here you see different children. You see down a child that has a dysmorphic features that is very difficult to put any eye frames over the head. Here we have the Down syndromes that we all know that they have a flat nose, so they will need a lens that we have a nasal bridge. So this, for the compliance, is fundamental in a children. It is important that there is acceptance in the parents, there is acceptance in the family, and it will be easier if siblings or the parents, they have glasses. And there are the compliance also can be related about school, sports, and friends. And that's why there are some movies like Harry Potter that they help us a lot in a moment to put glasses in children. The type of refractive error and the power, what we calculation, the prescription that is correct is important, but the lens centration is fundamental. Sometimes you receive a child that has the right glasses, okay, with the right prescription, but when they make the glasses, they're not centered in the pupil. If the child has astigmatism, he will not tolerate these glasses. So sometimes it's not only about measuring the power that is on the spectacles. You have to measure also the central part of the optical center and to put it on the face of the child to see if there is a centration of the lens or not. I always recommend in a child to have frames of plastics, no metal. This type that I have, I think is good. I tell the parents, you see the one that I'm having, to have it all the way up to the eyebrows, because the world of the child is down here, the world of the adult is up there. They will always be looking over the glasses, because if the glass is small, because the world is down here and our world is up here, up there. The compliance in myopia normally is good. In hyperopia, if there is a high hyperopia with full correction, they will say that they don't see well at far. But in this case, what you need in sometimes with the full correction is because they have isotropia or when they have amblyopia. They need to wear the glasses the whole time for hyperopia and the correct frame so they don't see over the glasses. If not, they will accommodate, they will relax. They will accommodate, they will relax, and they will have problems. In astigmatism, we already talked that the optical center has to be correct, the interpupillary distance correct, and the frames ideals are those frames that are without nose pads. This is the glasses the way that we want it. Some children, they need, because they have a special need, sometimes tinted glasses. It's recommended the tinted glasses to be used outside and not inside. Depends about the pathology that they have. And this is an old photo in 2014. I'm from Venezuela. And I used to see all the Down syndrome patients from Fundadown. And they were so kind that they invited me to participate in one of their calendars. And I just wanted to share you this picture. So thank you so much for your attendance.
Thank you, Dr. Pedro Matar, for your insightful talk. I'd like to request all the audience to put your questions related to this topic in chat box so that your questions will be addressed in our panel discussion after all the session. Now, we'd like to go for Jordan Studio where my colleague Javin Jaffer is waiting for you. Over to you, Javin.
Hello again. I'm here in this amazing country which is known for its archaeological sites, beautiful landscapes, and amazing Jordanian arts. Let's call our third speaker of this evening, Dr. Ezan Gamu, to discuss about innovative treatment strategy for myopia. He is currently working as an associate professor in Al Ahliya Amman University, and he is a chairman of Education Committee in the World Council of Optometry. Over to you, sir.
Good evening, everyone. Thank you so much for allowing me to speak, and I would like to thank the previous speakers. So, tonight's talk going to be about innovative treatment strategies for myopia control. I'm Yazan Gama. I'm an associate professor of optometry at Ahliya Amman University. I also chair the education committee of the World Council of Optometry. And as Dr. Alex has mentioned about SPECS 2030, I'm the foundation, one of the foundation committee members. I chair the workforce work stream. So just to disclose that part of the materials presented tonight will be taken from the IACL contact lens course and the myopia epidemic website of the World Council of Optometry. So we're going to talk about patient-centered approach. We'll select some intervention methods, and we'll talk about some ongoing myopia management options, and hopefully conclude. So our host said welcome from Jordan, and I'm telling you hello from Jordan. Just sharing some of the children photos that I used to work with over the years in school eye health programs, and some of the children who participated in some of the studies that Dr. Alex have mentioned. Since I came back from the UK, I've decided that I'll start working with myopia because all my research and both my master's and PhD were on myopia. And I thought, well, Let's serve the children now and preserve their vision so that hopefully myopia won't progress to the pathological limits that we will expect. So, Dr. Alex have defined the refractive errors and metropia, including myopia. For the sake of unifying refractive error definitions, myopia has been defined per the International Myopia Institute as a spherical equivalent of minus 0.5 diopters or less. And this is something exciting because whenever you want to read about effect of a certain myopia management option or prevalence of myopia in any group, you need to look at how myopia or any refractive error is defined. If we set the limit as equal or less than, it will be different than less than half diopter, or some researchers set it as a quarter diopter or even one diopter of myopia. So some use the spherical equivalent, some use cycloplegic, some use non-cycloplegic refraction. And as Dr. Alex showed us, it does show a significant difference based on the method you use. So this is something you need to bear in mind. And to be honest with you, the minus 0.5 and the minus 6 diopters or less, or in terms of high myopia, have been set based on research, but really there isn't much of the physiological changes that made us put these definitions. So this is something to think about. And Dr. Alex have already discussed about the progression of myopia during school age years up to adolescence and early adulthood. Probably all textbooks that we studied told us that myopia stops by the age of 15. From my humble experience, from lots of research we've seen so far, myopia tend to increase even in early adulthood, and since they coin it adult onset myopia. In terms of the epidemiology, I've redone the numbers from the late Brian Holden paper on the projection of the prevalence of myopia. So we're approaching 2030, so we're probably around 35% of the whole world being myopic. We've already seen from that systematic review about the distribution of refractive errors in the Middle East that we're not as myopic as some parts of the world. But remember, some of the studies that were included there did not follow a standard myopia definition or assessment techniques. Anyway, we need to remember that by the year 2050, half of the world will be myopic, which is very alarming. Thus, all the efforts that is done, that are done, and right now, while we're meeting, many of our myopia colleagues are meeting in China, having the International Myopia Conference there, and I'm very keen to see the output of some of the research that has been done there. Speaking about WHO, in their World Report on Vision, they called for people-centered eye care. It's sometimes difficult to think about people in general when it comes to eye care, so I thought maybe just we'll focus on patient-centered eye care at the moment. And from observation, working with clinicians in the region, translating risks and benefits to both parents and the children is something we need to do because we're not doing it very well, to be honest with you. Simplifying complex information for easy understanding. and empowering patients and families in decision making. I want to move from refractive errors and myopia, talk a little bit about low vision. So in 2019, prior to the COVID pandemic, we didn't have a proper low vision clinic in tertiary and any tertiary care center in my country, and I've been approached to start that. And the first burden and hurdle that I faced, that doctors do not communicate well with their patients, to be honest with you. When they come to the low vision specialist for the rehabilitation or offering the devices, they start asking us again about the disease, the entity, the prognosis. And these things patients really need to know. Okay, probably with low disease related to low vision, they could feel it, but how can you convince parents or children that myopia, which is very common and can easily be corrected with spectacles, will lead to such issues that needs to be managed, not just corrected. So fostering open dialogues is important, and collaborating on treatment decisions. We'll see some of the treatments, they might not be the best decision taken by either the parent or the practitioner. I want you all to have some empathy for your patients. Never sympathy, always empathy, of course. You need to acknowledge and address uncertainties, please, and try to tailor your communication to individual preferences. And this is something very important. It's not a one size fit all situation when it comes to management of refractive errors, especially myopia. Education and engagement is also quite important. You need to provide resources for ongoing understanding and always keep patients and families informed of progress. In selecting the intervention method, you need to identify the myopic children or who are at risk. So you need to evaluate the risk factors. And as we just said, tailor the management options based on the patient-specific factors. Safety, patient compliance, and costs are crucial. Dr. Pedro talked about compliance. This is very important. I always tell them, even with the best ophthalmic lens ever produced by one of the great companies, if the child does not comply, all our efforts are gone to waste. So this is something very important to consider. We need to discuss contraindications and openly communicate expenses with parents. Probably us clinicians in the examination room, we do not like to talk about costs. I know in some countries it's not even ethical, but you need to start preparing your patients so that when you communicate with the hosts at the counter area in the sales department, they won't be, let's say, shocked. But in my personal opinion, discussing cost options for myopia management with clinicians and the patients sometimes can be done in the examination room. We can always discuss this when it comes to the questions and answers, and I'm very happy to debate it. And I love to hear other people experiences. But these are one of the rare options that one can allow themselves to discuss costs there. So environmental modifications, optical methods, and pharmacological agents are currently the go-to options. So all the images that you will see, I either took permission to reuse, or I took them myself, or I've collaborated in one of the projects that have been shown here. Role of outdoor activities, I cannot emphasize its importance. A minimum of 8 to 15 hours of outdoor activity per week is recommended to achieve clinically meaningful protection from myopogenic stimuli. This is very important. I always support the fact that protect the children from actually becoming myopic. And this is the role of outdoor activity. And the chance of a child becoming myopic is actually reduced by around 1/3 if the time spent outdoors is increased from around 0 to 5 hours per week to 14 or more per week. So this is quite important. Small change in lifestyle will dramatically change the myopia pathway. All right. You'll ask me what are the factors. Several factors have been suggested, such as the depth of focus induced by pupil constriction when you are exposed to light, dopamine release. Some studies support that. Vitamin D levels, all are controversial. Unfortunately, some studies on children are restricted in terms of the way we can do them because they are humans after all. So we need some ongoing research about that. Remember that excessive near work may influence the development and progression of myopia. So greater odds of myopia progression or onset will be with close reading distances, continuous reading for more than 45 minutes, head tilt. This is quite important. And you can see half of the children, well, it's not an ideal studying environment, but we actually have this in my country. And the closer nib to fingertip distance, which means greater head tilt, is making things worse. Remember, children should not be prevented from participating in near work activity, but always you need to pay attention to the regular breaks. They need to have them, appropriate reading distances without the head tilt. This is quite important. Sometimes I even remind my daughters, chin up, straight head. That's very, very good to remember. And the near to distance fixation changes while reading with sufficient outdoor activities. We need to break the accommodation cycle. Anyway, the Erasmus Myopia Research Group in the Netherlands do recommend complete absence of close-up screen use for children up to 2 years old. I'm using this platform to urge you and talk to your patients, your parents, not to use any screens under the age of 2. Probably maximum of an hour for children up to 5 years, maximum of 2 hours of screen time after school, of course, between the ages 5 and 12. Talking about outdoor activities, environmental modifications, it's always worth to discuss in nutrition. Lots of health issues may be connected to nutritional habits. We're aware of that. Probability of eye diseases are related to some dietary habits. Two theories are currently going on. Little bit weak evidence, so we need to observe further. Some studies have linked myopic progression to low fat and low carb intake, where our diets high in saturated fat and high cholesterol have been linked to increased axial length. So that's very interesting. And some studies linked caffeine metabolite with the potential to reduce axial length growth in children. I'm not saying we need to have to give coffee to our children, but the idea is it's very interesting to monitor the research there and see what will be the recommendations. So let's talk about optical methods, and we'll start with the humble pair of spectacles. We are having a crisis in our region, as you are aware. I live in a country where we've hosted so many refugees, and last few months, I'm not sure if I was blessed or not by I'm one of the very few non-governmental individuals who was able to enter one of the refugee camps. I was invited there to assess the eye health conditions. And sadly, although they have some setup for an eye examination with an ophthalmologist coming on a part-time basis, they never had a pathway to deliver spectacles. And without good vision, I don't know how the children will be able to study and grow up and be productive in their adulthood. So this is something we need to consider. Anyway, I would always advocate for spectacle lenses, especially in our region. Anyway, very young children are not able to wear contact lenses, are probably there are access or cost constraints. Some of the contact lenses approved for myopia management do not even exist in some parts of our region. Uh, Poor hygiene related to microbial keratitis, although we know the risk for high myopia and its related disease is higher compared to the odds of contacting microbial keratitis. However, it's better safe than sorry. Um, as we said, with limited or no access to specialized eye care, following up with patients with contact lenses is going to be a hassle for the parents and the children. So spectacle lenses are preferred for so many reasons. We need to ensure that staff are aware that children should wear their spectacles for full time. They better to have a spare pair because we know children usually sometimes break their glasses. And for those who might want to consider multifocal and bifocal options, though I do not support them anymore, they need to bear in mind that it has been shown that children deliberately leave their single vision glasses at home. May do this more if they are not well tolerated or are not cosmetically attractive. So you need to consider that very well before you even want to prescribe them. Many optometrists still unfortunately utilize undercorrection of myopia as their standard care for myopia control because it was once thought to induce myopia defocus on the retina. Undercorrection unfortunately speeds up progression. Okay. You need to assess the rate of change of refraction and set recall appropriately. You need to ensure, even if patients are wearing soft multifocal contact lenses, they need to always have a pair of myopia managing spectacles with them all the time because children cannot simply wear their contact lenses all the time, every day. Remember that, okay? So talking about PALS, they may have a myopia progression, but it's not that clinically significant, around less than 20% rate in average when used on its own. We do not offer it as the first option. There are very good, excellent, specialized myopia management ophthalmic lenses now in the market. So you need to be very careful, all right? And remember, with PALS, frames should be regularly adjusted as the downward slippage of the PALS will reduce the myopia control effect. Okay? So you need to consider that and always think about shorter corridors to ensure that the child is looking through the near addition, the plus area as much as possible. Okay? We'll move to our peripheral defocus spectacles, our treatment of choice lately. They've been showing excellent efficacy. These lenses, as shown here, have a typical central optical zone for clear vision and a defocusing outer lens portion, or we want to call it a treatment zone. So the goal is set really to create an environment which in front of the peripheral retina, there is a blended distribution of myopic defocus. And by doing that, it's believed that the eye growth may be slowed down, potentially reducing the progression of myopia. So, as I said before, such designs should be considered instead of single vision spectacles. So consider them as your first choice of treatment. Some companies actually offer two designs for younger and older children, which is really quite interesting. And I really like that. And the designs differ in the central zone clearance area, which is usually smaller in the younger group. And the mean add surface power in the peripheral area is a little bit less in the older group. This is good as it will allow for easy adaptation for children. Okay, talking about multifocal soft contact lenses, we have off-label use of the lenses that are used for presbyopia. We can simply also use them uh, off label for myopia management. However, there are specialized FDA-approved soft multifocal contact lenses, and they are showing a good promise with some good follow-up studies. However, they might be limited in your market. They might be costly. The follow-up sessions will be more. The risk of hygiene is more, and you always need to have a second pair of myopia management spectacles with them. All right, so this is something you need to consider. I will not go further into that. Ortho-K, and interestingly enough, I'm having a debate with one of my colleagues in Dubai about Ortho-K versus peripheral defocus ophthalmic lenses. And regardless, they both doing very well. Ortho-K actually have paved the path for myopia management. We need to remember that. But the idea is fitting is somehow challenging a little bit. Follow-ups, cost, microbial keratitis risk, all of these should be taken into consideration, plus a specialized use of a good corneal topographer and following up of axial length using an optical biometer is very important. And I am aware that many optical stores in the region do not have readily available an optical biometer and a corneal topographer. So these things will add cost or maybe challenge you in the way you manage your patients. I'm not gonna spend much more time. We're gonna cover only a couple of options now. Atropine has been studied a lot quite lately, especially in its low doses form. By creating some myopic defocus, some other pathways as well. A common recommendation involves applying one drop of 0.01 in each eye once daily, typically at bedtime. Some studies have been mentioning that 0.05, no 0.05 is recommended better. However, we need to remember, regardless, that these things need to be compounded by pharmacists if it's not readily available. Many of them are not FDA approved. Many of the readily compounded by some of the companies do not have the proper registration or licensing to be marketed outside their countries. Big limitations in terms of atropine. Remember that patients will need to be prescribed their full distance refractive correction. Patients sometimes may require near addition correction to alleviate some of the near visual symptoms. Some children actually might need some sunglasses to relieve the glare issues. It just all depends on the patient. Some of the studies show that patients require these, some patients or some children in some countries, they didn't. So we need to be aware of these things. We need to ensure the rebound effect. And this is something we need to consider heavily with atropine. After myopia, or after discontinuing or cessation of atropine, we will see an acceleration of myopia progression, although much less with the 0.01% dose, it's still there, unfortunately. Okay. Patients and parents should be aware that that this rebound effect should be considered. We're still not very aware of the long-term use of atropine and its long-term side effects because it still haven't been evaluated fully. And we still need to ensure, even if we stop using atropine for myopia management, uh, the children need to go to the doctor, to a ophthalmologist, or to their licensed optometrist for further 6 to 12 months monitoring to ensure no further rebound or no unnoticed long-term side effects. So I've seen this study published very recently at the Ophthalmic and Physiological Optics journal. It's a systematic review of the rebound effect of different control options. They haven't covered all the options, by the way, just as a disclaimer. However, if I just want to summarize it a little bit, they mentioned that the rebound effect of peripheral defocus ophthalmic lenses in general and multifocal soft contact lenses is lower, the rebound compared to atropine. Uh, Almost 3 times more rebound effect with atropine, if you just want to think about it in that way. All right. Last but not least, low light level red light therapy. This is quite recent. We have very few limited studies, and they're mainly from China. The efficacy is questionable. The study design still needs to be refined a little bit because during COVID lockdown, some of the intervention groups had compliance challenges, and there was some impact on the continuity of treatment. So we're still having a relative reduction effect of around 1/3 with low-level red light therapy, though still, I would caution you that we need to see more robust studies on that, a stronger control group, and stronger protocols to ensure that this is available. And we also need to identify any side effects when using red light therapy with children. Okay. Another study also focused on Chinese children, and they asked them to have at-home desktop light device emitting red light at around 650 nanometer, twice daily, 3 minutes for 5 days a week. They had half a millimeter less axial elongation. However, the rebound effect was high. 40% of the children actually had accelerated axial elongation after 1 year of cessation. So this is something to really consider. Anyway, to conclude, personalized approaches should be considered. Safety, compliance, and cost are crucial. And here, definitely, I would advocate for ophthalmic lenses. You need to stay current. I know you are very busy with your clinics. You might not have the interest in reading research. However, we're here. We're here to support you in any way possible. Actually, we would not have spent our evening out of nowhere because we want to serve the practitioners in the region. Anyway, I know we have an ophthalmologist among us, but I want to send a message to optometrists, especially at this very difficult time in our region. Remember, we are facing so many conflicts beyond imagination, and some of my own family members have been affected. So, if you need to excuse me if I'm not at my best tonight, always never doubt how vitally important you are. Never doubt how important your work is, and never expect anyone to acknowledge it before you do. Every moment, in everything you do, you're making a difference. In fact, you are in the business of making a difference in other people's lives. In that difference lies their healing and your power. Never forget it. These are my references. Thank you so much.
Thank you, Dr. Ezra. That was indeed an amazing talk. Let's move on to our next talk from German studio. Over to you, Mr. Swarnakamal.
Thank you, Ms. Javin Jaffer. Now I am here in this country which gave us the extraordinary Nobel Prize winning scientist Albert Einstein. Yes, here I am in Germany. And guten Abend to everyone. I'd like to call our speaker from Germany, Ms. Alma Manukar, to talk on interdisciplinary collaboration and comprehensive care. Over to you, Ms. Alma.
Hi everyone, thank you. Your German is excellent. Guten Abend. And I will start to share my presentation just in a second so I can start without wasting too much time. So I'm assuming you can see my presentation. And what I'm going to do is I'm going to cover, let's say, I'm going to reinforce what is told until now. There is nothing much new, but you'll get the terminology to describe certain forms of collaboration between eye care professionals. Just a bit about me. My name is Alma, as I was introduced, and I have spent more than 10 years in eye care industry. I've worked in refractive clinics, hospitals, optometry practices, and the last 6 years in the industry. So my job consists of observations. I look how optometrists and other eye care professionals like ophthalmologists work, and I try throughout my observations to come to conclusions, products, and solutions so I can empower you to do the best job that you can, keeping always the patient in mind. So today, what I'm going to talk about, I'm going to talk about collaborative care when eye care professionals work together and why is that so important. There are some benefits that are for all the stakeholders included, I would say. The models of collaborative care, like across the globe, you will find different models of collaboration, opportunities for you to collaborate, and how to make it successfully. So what I aim at the end of this presentation is, I know you will agree with most of it, and I know that you will make the best out of your models of collaborative care to offer the best care to the patient. So I think this is the right audience because I'm assuming that you are not only working in hospitals, you might work in optical stores, in hospitals, clinics. So it's a very diverse audience that I'm expecting to be here listening. Well, I will start with the definition of collaborative care and why is it beneficial. So collaboration or collaborative care is a care model that aims to increase cooperation between patients and teams of healthcare providers. So it benefits all of the people involved in it. So optometrists, ophthalmologists, and mainly the patient. So why it is important for the patient? Because if you talk to each other and you collaborate better with each other, it enhances patient care. So problems and issues are addressed very early on. It mitigates medical error, which means you come faster to conclusions and you find the right and the effective medical management. It expedites the initiation of care. You encourage interprofessional collaboration because it reduces silos of care, it bridges gaps in communication, and it leads to faster and better solutions all the time. And I am very much aware that there might be conflicts or misunderstandings, but everything can be overcome. To the eye care professionals, optometrists and ophthalmologists, it bridges knowledge and communication gaps. So as the different speakers here also mentioned, and I can only confirm it from my side and from my observations, you bring complementary skills to the table. So if you talk to each other, you will share this kind of knowledge and information. you will understand that there are overlaps. So there are parts who can do only an optometrist and other parts who can do only an ophthalmologist. And in other cases, there will be other eye care professionals involved. And only working together, you can offer the best care. So if I would summarize all these benefits, I would put the quality of care, it increases, like referring or working with each other, it increases the quality of care. It leads to long-term collaboration between eye care professionals, but also long-term collaboration and care for the patient. Just to remind that refractive error overall, it doesn't stop at aging. It doesn't stop with the age of, teenage age or so. As some of the doctors also mentioned, it continues sometimes throughout late on the early years. And then, thanks God, we have eyes all the time, and we always going to need sometimes some kind of intervention from any eye care professionals. And it comes also with financial benefits. So what does that mean? You get more effective. In cases where, for example, you talk to each other and you know exactly what the patients need, you can avoid the part of trial and error or of trying different solutions and failing. And by just talking to each other, you can just spot the right solution for the patient. And when it's involved, for example, in refractive surgery management or cataract management, in some countries, there are fees, and this is also very regulated, that you can share also the cost of that care. In other countries, it works differently, but I think you are very much aware that the profession of optometry across the globe is very different. In some countries, it's very much well established and well known and regulated, and in other countries, it has a different scope of practice. So, having said that, I will talk about the models of collaborative care. There are 3 models of collaborative care, and no matter where you are across the globe, no matter how recognized your profession it is, you are navigating in one of those models. For example, I have here the 3 names: the coordinated care, co-located care, and integrated care. And I will explain how they might look across the globe. For example, coordinated care. So this is typically in countries like, for example, US or UK, where optometrists have a broader scope of practice and a lot of independency. They can do a lot of measurement and assessments. And obviously, in some cases, like, for example, chronic disease management, they will require to work with ophthalmologists. In most of the cases, they can handle many of the issues or many of the topics of primary eye care by themselves. And it works like this. So they have their independent practice. They do primary eye care. Sometimes they are specialized. And when they encounter patients who need special care, they will refer to a ophthalmologist or to a surgeon. In co-located care, it could look a bit different. So it's, for example, a hospital where optometry and ophthalmology, they work in the same setting, still separated, but they communicate very good with each other. Like, they're all the time exchanging patients. Optometrists do preoperative assessment, do all the measurement that are needed, for example, in the case of myopia progression management. Then they refer to the ophthalmologist, which does other measurements, complementary, and they will prescribe a solution to the patient and bring back to the optometrist to finalize the post-care, I would say. And integrated care, I think this is the most common, is when in your region, I would say, where you and so the ODs and the ophthalmologists are working together in the same entity. And here the roles and responsibilities are very clear. However, again, collaboration and communication between the 2 professions is key to a successful patient flow. So I think everything was mentioned until now, in which areas collaboration is necessary, or it could be very successful, but mainly necessary. Like, it is required that you talk to each other, that you share all the information, that you share data, that you share all the measurements that you do, so you come to a better solution for the patient, always keeping in mind the patient needs. That is, for me, as an optometrist, also the common ground between the two professions and also other eye care professionals like orthoptists. So I brought here 3 examples. In my career, I had the chance to have a look or to observe a lot myopia progression management, how it is done in different countries. And right now I am in a refractive surgery, and I also see that it is absolutely necessary to be collaborating and communicating better with the optometrists. If you are in a refractive clinic, but also if you are referring patients and you are in one of the countries that I mentioned, and also in chronic disease management. Now, chronic disease management is not part of the refractive error, like it's a bit, I would say, indirectly related. However, is one of those areas that requires the eye care professionals to work together, as the nature of these diseases requires early detection and early management. But let's take them one by one. So I will not tell anything new, but what I observed, it's put like in a summary, and why myopia progression management makes actually the best case to collaborate together. So it can be offered, depending on the country, in all the 3 types of co-management. It can be offered as an integrated or co-located modality of collaboration. In other countries, it's done completely by ODs, optometrists. So the collaborative approach here would leverage the strength of both the professions. So I know for a fact in certain countries, as an optometrist, you are not allowed to do all the assessments. Therefore, it requires the ophthalmologist to be taking some of the measurements to prescribe, and then you can proceed at preparing the spectacle lenses and fitting them. So what drives this collaboration? What triggers it, or what requires it actually? The patient age group. So these are children in most of the cases, or young patients. And at least for the Germany, but again, it applies in many other countries, optometrists could not apply any pharmaceutical to delay the eyes. So they are not allowed to actually refract patients, so children. So it has to be done from an ophthalmologist. The nature of myopia itself, it's a multifactorial condition, and it needs all these bits and pieces of information from the different professionals and people you work with. And the available solutions that were just mentioned, that it's not just one solution that fits everything or every condition. There are many out there, and some of them are off-label, some of them are approved in some countries, and because of they require also different skills, working together, it would make the work easier and better for the patient. Another part is the pre and post-surgical care. So here I refer actually to a refractive error again. And here are the cases where refractive surgery or clear lens extraction. So also in these cases, you need to manage refractive error, but in adult patients. Now, what you might know, or many of you might be doing, you work in a refractive clinic or in an eye clinic, and you are doing all the pre-assessment for these patients. The surgeon is doing the surgery and sending the patient back for postoperative care. And again, also in these cases, a good collaboration, it is absolutely necessary for better patient experience. The factors that drive collaboration here is, again, increased efficiency. Better collaboration, it means you achieve the goals way faster, you reduce the chair time for the MD, and it improves patient experience overall. Like when everybody is in the same page in the clinic, it feels better for the patient. And very briefly on the chronic disease management, it is also offered in different collaboration modalities across the world, again, depending on the scope of practice that the optometrists have. Despite that, I believe, and I have observed, that constant collaboration and knowledge sharing here also is very, very necessary for successful disease management. What drives the collaboration here? The patient age group. Here we have to do with aging population, and there is high demand for detecting and monitoring diseases, chronic diseases early on. the nature of these diseases is also very special because not detecting them early enough and not regularly keeping an eye on them, monitoring them, would result in loss of vision. So the mitigation, so it is necessary, a kind of collaboration. And then mitigation of medical error, which is needs of utilization of complementary skill sets for effective medical management. So again, I believe that the two professions are so important, or even more professions, because again, there are different eye care professionals involved for different conditions. And again, when there are always overlapping skills, otherwise they would not exist. And it is necessary that you talk and collaborate with each other. Sometimes there is infrastructure that enables that, communication pathways, and sometimes you have to build those bridges by yourself. And I'm very happy that there are way more eye care professionals that are willing to do so and are willing to collaborate for a better job. Now, okay, collaboration, how to make that successful? Like how to not see each other as competitors, instead as partners at working for different reasons. Again, in different countries, it looks very, very differently. So I have put here 3 pillars that you need to use as a baseline for successful collaboration: transparency, support, and communication. So transparency, these are just examples. Again, transparency for each clinic or each hospital you might be working on, it could look differently. However, a simple staff introduction, knowing with whom you're going to be working with which doctor you are partnering, would make the job easier for both sides. Observing the patient flow. Take a look like you are every day in the clinics or in the store, in the practices that you are working, and you get very caught up in the daily routine. Take time to observe how the patient flow looks in each clinic that you might be collaborating with, but sometimes also in your own clinic, so you can understand where are the bottlenecks and where there is necessary to do some changes so you can offer better service. And the diagnostic devices. The previous doctor mentioned you don't have a biometer in each optometry practice. Fair enough. The scope of the biometer was foreseen for cataract. However, it is very necessary to track the action length in myopia patients. So sometimes you don't need to share the devices, but you can share the information, the action length. So it is easy to track no matter where you are set up. Shadow, if you are collaborating or not on the same place, like just partnering with each other. Shadow the clinic, shadow the practice that you are collaborating with, which is look and take a day or take time to look how everything is done, from the consultation, from the fitting, from the patient flow, and everything that is part of the patient journey. If you are collaborating for refractive surgeries or cataract, again, shadow the surgery so you are familiar of what is going on there. You don't have to know how to do the surgery, but you have to have seen it at least, and how the doctor you are partnering with is doing that, so you know to prepare the patients what to expect. And last but not least, in terms of transparency, have a conflict resolution plan. So conflicts and misunderstandings might be unavoidable, but so are the solutions for that. So establish a clear plan in case of any problem. How would you deal with that? And put a dedicated person who is to be contacted in such cases. Support. Now, collaboration requires support, a dedicated person, sometimes just supporting each other with services, with educational needs, and with feedback. So the doctor again mentioned, like, we sometimes don't know how to communicate to the patient. Like we get caught up again in very scientific content that the patient cannot relate with or might be overwhelmed. Share the information, tailor it to the patient that you have, share it with other clinics that you are working together so you are all on the same page. And again, gather a lot of feedback and try to implement that feedback as soon as possible. Communication. So yeah, communication is also one of these with very different aspects. However, communication is that element that will make the work easier no matter where you are. So you have to get access to the doctor and to the internal, in case you are not working in the clinics but just referring or co-managing patients. Just be clear on how you're going to communicate with each other. Prepare like referral solutions, or how you prefer to be talked to. Like, do you prefer to be talked on the phone? Do you prefer to have a letter? Do you share the patient information digitally or manually or both? So refine all these things beforehand so everybody is again on the same page. For example, here in Germany, we prefer everything written, everything. And if it's not written, it never happened. And keep that also in consideration. Referral recommendations. So personally, optometrists, for me, are, at least, even though I'm not directly in the practice, I know they are the gatekeepers of eye care. So they are the first one that you go to as a patient when you have any issues with your eyes. And if optometrists are well informed, they know all the available solutions. They have a right network of eye care professionals working together. They could be the ones who could recommend the patients to the right eye care professional, like just based on their needs. Some patients are not happy with spectacle lenses. They are not happy with contact lenses. I don't say you have to recommend refractive surgery to every patient, but you should be aware that for certain lifestyles, profession, eye conditions, maybe refractive surgery could be the solution, or the opposite. Some people want the refractive surgery, but they are not meeting the requirements for the refractive surgery. So the optometrist should have this awareness of catching this kind of information early on and help the patient to make informed decisions. Now, staying compliant. Compliance, a very important topic. It doesn't matter if it's a child wearing any myopia progression management solutions, or an adult, or you trying to co-manage with each other and trying to stay ethical in your work. In many countries and regions, this is regulated by the government. So you can or you cannot do, or you can do referrals only under certain conditions. However, when it's not regulated, I would say just keep in mind that any decision that you take, it has to be patient driven. So keep your patients in mind, keep their needs in mind, and only then you can recommend the right solution. It doesn't matter where you are, or the right professional. Take the informed consent. It has to be a shared decision. So you have to inform the patient about their options. Like, what do they have? What is available out there? And give them the autonomy to choose, partially choose, maybe in some cases, what aligns better with their goals. Shared decision making is like engaging the patient in shared decision making, like discussing the benefits, the risks, the alternatives. And this is applicable to myopia progression management as well as to continuing refractive error conditions throughout the adulthood in the life of the patient. And last but not least is the customized care plans. Again, not one size fits all. Every patient has individual needs, and you make sure that you meet those needs, not only with the solutions that you offer, but also with the professionals that you choose to work with and to recommend or to connect with the patient. Now, there is one key element that I would like to mention here. When I say stay compliant, is also keep in mind what are the laws and regulations in your area. What should not be done? Is the patient aware of everything? Is the patient aware of the payment? Is the patient aware of the relationship that you have with the other eye care professionals that you are involved? So everything should be clear and should be compliant. So this is just, for me, it's not a recommendation. You have to do that or you have to do this. Again, this might be your daily work in most of the cases. However, I just wanted to bring this together and to say, like, to give some definitions and to make it easier for you to say, no matter where you are involved in certain forms of collaboration, and you have the choice to make it fruitful and to make it successful keeping in mind the patient needs. And for me, the patient is also that common ground that no matter what you do, if you are an eye care professional or a heart surgeon, at the end is that patient that you are doing your work for. So keep that in mind. And again, just to summarize and to reinforce what I said before, that your job is very important and that you complement each other in terms of skills and knowledge. So thank you very much from my side for the attention.
Thank you, Ms. Alma Manukar, for this extraordinary talk. Here we announce that we finished all our talk for today's session. Now it's time for panel discussion. So we'd like to go back to UE studio for the panel discussion, and I would like to all the audience to put your questions on the chat box so that it can be addressed in the panel discussion. For the panel discussion, I would like to refer to UE studio where Ms. Devkani is waiting for you. Over to Ms. Devkani.
Thank you, Swarna. Good evening, everyone. I hope you all enjoyed the wonderful presentation. Before we move to the panel discussion, I would like to invite Ms. Celine Cambrose from Vision Care to share a few words on latest studies results with CAD technology. Over to you, Ms. Celine.
Good evening, everyone. First of all, I really would like to thank everyone tonight. I think it was really, really interesting to be all of us able to talk about all those very interesting subjects. And so I'm not going to take a lot of time because we already did a lot of things and heard very, very interesting things, but I just would like to give you some updates about MyoCare, ZEISS MyoCare lens. I hope you all see my screen. Okay, so first of all, what about ZEISS MyoCare lens? It's not our first webinar. You already know, I believe, for most of you, what is ZEISS MyoCare lens, but let's have a little refresh here. So ZEISS MyoCare is a new lens with peripheral defocus made by ZEISS. It's available since 1 year already in UAE and now available in many different countries in the region. This lens is going to slow down myopia in children. You have the design here. So we have a central zone. Then we have what we call a functional zone, where we are going to add additional power thanks to the care elements. And between all of them, we are going to have the regular power. So what is very challenging here is to find the right size of the central zone where the normal correction is, and then what is the best value of the care elements and how to do the distribution between those care elements and the normal correction to maintain comfort, because we know that if you want the solution to be efficient, we need to prioritize, at least not compromise on comfort for children. So yes, we needed to find the best size of the central zone, big enough to be comfortable for children doing activities and small enough to have an effective functional zone. Then we needed to find the best way to add this power on the front surface. So we have created this technology, which is called care element, cylindrical annular refractive element. It's going to be a positive power at the front of the lens, which is going to create a myopic defocus in front of the retina, and so that a stop signal is going to be sent to the brain to stop the elongation of the eye. On top of that, as I just said, we needed as well to find the best balance in the functional zone between these care elements, this positive power and the normal refraction. We also have on the back side of the lens a second technology, which is going to minimize the hyperopic defocus, which is involved by a normal single vision lens. And this is actually what is stimulating the elongation of the eye. So it's great to have this positive power on the front surface of the lens, but we also need to minimize the hyperopic defocus. So we have a second technology, which is called the ZEISS clear focus design. It's a point-by-point free-form optimized back surface design, which is going to minimize this hyperopic defocus and maintain the efficacy of the care element in the front. As Dr. Yazdan said just before, we are really happy to provide you today two types of MyoCare hard design and MyoCare soft design. MyoCare hard design is going to have a central zone about 7 millimeter, when the soft design is a little wider with 9 millimeter. The power, additional surface power is plus 4.6 for the MyoCare hard design and plus 3.8 on the soft design. What is interesting is to see that we have exactly the same distribution, which is 50-50 on the functional zone. 50% of good correction and 50% of additional surface power. You know me for quite a long time now. It's not our first webinar, and I have been talking to you about studies, and I think it's really important for now to talk to you about the latest results that we have. We have now more than 1,700 children under study. This is really where ZEISS is investing the most. It's into research. What I'm going to share with you now are intermediate results of a 24-month study from China and a 12-month study from Europe. This study in China is going to be a 2-year study. It's a multi-center clinical trial. We have 240 children involved into it, divided into 3 groups: a control group, 1 group wearing MyoCare soft design, 1 group wearing MyoCare hard.
Hi, Celine, you are muted.
Hello, everyone. Can you hear me?
Yes, yes.
Yeah, we can.
Okay, I've been talking that much. Okay. So, can you see my screen at least?
Yes.
Okay. Let's do this. Okay, so I was talking about the clinical trials that I wanted to share with you. We have now more than 1,700 children under studies. I'm going to share with you the 24 months study from China. I mean, it's intermediate result of 12 months in China and the 6 months intermediate result of a study from Europe. So this is going to be a 2-year study in China. It's a multi-center trial. Okay, and we have 240 persons involved, divided into 3 groups. 80 of them are in MyoCare soft design and MyoCare hard design. What is really interesting to see here is that we have a very low number of dropout, which is a very good sign. It means that the adaptability is very high. So after 12 months, when we compare to the control group, we are already slowing down the myopia of 0.31 dioptry with MyoCare hard design, 0.13 millimeter for the axial lens. About MyoCare soft design, 0.29 dioptry and 0.11 millimeter. So even in 12 months, we already know that it's slowing down without compromising comfort. We had distance vision, near vision, drink spot even going up and downstairs. It's very comfortable. We had this discussion a long time ago, and it's really important to understand that there are so many parameters having an impact on the evolution of myopia. If you're coming from Asia, if you have one parent or both of them already being myopic, if you're spending 8 hours per day outdoor or 8 hours per day on the screen, the influence on the progression of the myopia is going to be different. And we cannot control those parameters when we are doing the study, when we compare to a control group. So what we want to do is actually to measure the efficacy of our lens by measuring how is the axial lens growing compared to the axial lens progression of an emmetropic eye. That's where we are removing all those parameters. And so when you took those data from the Chinese study, what is interesting is that we are slowing down and taking back this curve as close as possible to the one of the emmetropic eye by 70% for myocare hard design and by 68% for myocare soft design. So yes, in even 12 months, it is working on both designs. We said previously that really the myopia progression is dependent on country. Okay, we know that the heart of the fight right now is in Asia for many, many years, and we know that it's coming worldwide, but we don't have that many data. So we are doing a study in Europe. This one is a multi-center trial in 5 cities in Spain and Portugal. It's going to be a 2-year study, and we already have the 6 months intermediate result. We are here trying only myocare hard design, but we have a huge number of children wearing the lens. More than 300 of them were involved in the study, and 150 are wearing myocare. After 6 months visit, that's the same. The number of dropouts is very low. Again, a very good sign. In terms of result, in already 6 months, we can say that we are slowing down myopia about 0.15 dioptry and slowing the progression of the axial lens of 0.07 millimeter without compromising comfort. More than 95% are good or very good at distance vision. More than 90% of them are having the same for near vision, even doing sports in a dynamic vision. I could spend hours to talk to you about studies and myocare, but I think you're already tired and you have questions and you want answers. So if you are interested about all our publication, we did all of those at AVO Congress. And right now, when I'm talking to you, some presentation and studies results are done at the International Myopia Conference, and you will be able to see them next week. Some updates about all we can provide to help you with myopia management in your practice. This is already what you might have or what you can request. Leaflet for parents, display with the lens. You have this follow-up booklet to make connections between the ophthalmologist, optometrist, parents. Everything is available in UAE in different countries. We are launching just right now for VP Expo and Optoverse a new tool, which is a children's size desk. On this children's size desk, we are explaining what is myopia. You have games and quiz, you have diagram about a myopic eye. The idea here is really to give you a support to explain what is myopia to the parents, because we know that the behavior is having a big impact on it. The very good news is that we now have myocare stock lenses. The difference here is at first you're going to have them very quickly because it's already made, already available. And we have made really a very small price affordable because we know ZEISS is a foundation and we know that we cannot expect parents to spend huge amount of money on their children's health. The reason is that they just cannot. They just cannot. So here, starting from 950 dirhams, you can have 1.59 DuraVision Platinum myocare lenses. So it's from plano to -6 with a cylinder up to 2 included. Their diameter is 70. We still have a huge range of ARIC lenses. We now have the 1.67, which is available and that you can already order. You saw it from this webinar, and as I said, it's not the first one. We have been really trying to work on educational program and on tools to really help you to do myopia management into your practice. So this is a poster, a sum up, where you have every step-by-step guidelines to do myopia management. We have now a myopia education program, which is available on our website. So it's a 5 minutes program. It's going to take you, I would say like 2 hours, but at the end you have an assessment. And if you have more than 80% of good correction, you will have a personalized certification. We also are going to go to all main congresses, and I'm really happy to talk to you tonight about our engagement with Dr. Yazan Gamou. We are supporting the publication of his own ZEISS, his own myopia management guidelines supported by ZEISS. We are going to talk about them during all following congresses, and I will be happy to give you booklet about step-by-step techniques to do myopia management. During this Optoverse Congress, ZEISS Meditech is joining us, and we are going to talk to you about Press Beyond and SMILE. We will have different talks with really main doctors and surgeons and different workshops. So please join us at Optoverse. Finally, if you want to be updated with all latest news, studies, product, please join our LinkedIn group, which is a full ZEISS myopia solutions group. Alma and Dai are really pleased to share all our latest news. And I'm done. I tried to be quick because I know that you have a lot of questions. And of course, if you do have any other questions, you missed the first 2 minutes, but honestly, you already know everything about myocare, about the techniques of the lens. What is really important is really thank you, Yazan, for this deep collaboration about your own myopia management guidelines. And I'm really looking forward your different talks with upcoming Congress in the region. Thank you, everyone.
Thank you, Celine. Thank you very much for the wonderful update and for sharing the amazing studies and the clinical trials. That was really, really interesting. And now we are moving to the panel discussion. May I request all the speakers to join the panel, please, for the question and answer session. And I would like to invite Mr. Sujit Shah to chair the panel.
Hello. Yes.
Yeah.
I'm there.
So about Mr. Sujit Shah is a consultant optometrist, INFOR, Myopia Center Prevention and Control, Brian Olden Institute of Optometry and Vision Science, LB Prasad Institute, India. Over to you, Mr. Sujit Shah, to take over the panel.
Yeah, thank you so much. It was a very wonderful presentation for our speaker. I would just like to start the panel, our session. I would like to ask Dr. Alec that what influences the distribution of refractive error in different zones in the country? As you indicated that the prevalence of refractive error in the hyperopia is Iran and Eastern Mid East, but compared to the Africa and the Western Pacific. So what is on take on that?
I don't know. I don't know. I think that a lot of this evidence is now coming together in terms of trying to understand what may be influencing refractive error development in different countries. I think we can see that in countries where students are studying longer hours, then that possibly is one factor. The difference between urban areas and rural areas also shows that there is a prevalence of myopia more in urban areas compared to rural areas. So I think the evidence is being gathered. We don't have any definitive answers at the moment.
So do you feel that the outdoor activity plays a major role in terms of ametropic and compared to myopic? Because those who are already myopic, we tend to say that you have to be outdoor for mainly 12 to 14 hours a week. So how do you
Yes, I mean, I feel as though we have to protect, offer similar advice to children who are emmetropic, because there is still the possibility, as we can see, emmetropization doesn't stop at the age of 6, and can continue into teenage years, perhaps into adulthood. So I would consider people who are emmetropes in teenage years and even low hyperopes are still at risk of developing myopia at some point. So you know, yes, children should still play outdoors.
So I have a question for Dr. Pedro that as you talk about the hematopization and you highlighted that the visual experience and the genetic predisposition is a very important. So do you feel that as there is a importance of visual experience, because hematopization typically we said that till 6 years, and Dr. Alex recently said it's not about 6 years. So how do you take on that?
I do believe the visual experience is very important. It has been demonstrated that a child, if he's is born and you no child, it was I think that's an old paper done by Scott Lambert, that he published that in monkeys, when you get a monkey and you patch the eyes and you open the eyes after a certain time, after 2-3 months, the actual length will change. So that's what I would call about visual experience. So yes, I believe that there is a certain age during the visual development that visual experience can play an important role. And it is so important that even what everybody it advocates for children not to have an accelerate myopia increment is to go out and play outside and play more than stay at home and all those machines. So yes, there is a visual experience that is important.
Okay, thank you. I have a question for Ms. Celine. There are two questions for you. How MyoCare controls the progression of myopia? And the second one is MyoCare lenses available in Oman? You're muted.
Yeah, this time I'm on mute. Yes, it is available in Oman.
Okay.
Yes, it is available in Oman for ZEISS dealers. If there is any kind of request, you can directly ask to me, and I can put the person in contact with the one having ZEISS lenses in Oman. But yes, absolutely, it is available. And what was the second question, please?
Second question is how MyoCare controls the progression of myopia.
Oh, the myopia progression is actually really a worldwide problem. I mean, me and all of you actually, and Yazan, we are trying to express and to talk about it, because for a very long time we thought, and even ZEISS, all our effort was really into Asia, because it was really what we thought it was only for Asian people, but actually it's not. I have a study which was made in Portugal, and when you look the numbers of myopic people between 2010 and 2020, there is 10% more. So yes, we are having more and more myopic people everywhere, and all the complications which are going to be involved with it are coming. They are coming to your practice, and you will have to find solutions. And we know that every diopter matter. And so I'm so happy to come in this market with having a solution, non-invasive, which is scientifically proven to slow down myopia and quickly. It's really important to have long-term studies to talk about the rebound and to talk about side effects and so on, but it's also very important to have recent studies which are showing how our kids today, because the behavior changed with homeschooling, with everything, how they do react today to our solutions. So yes, pandemic is growing. Yes, in our region, it's not as fast, but it's there, and it's going to be faster and faster. And yes, everything is not available and not suitable and expensive. So I'm really glad that yes, MyoCare, both designs, This stock lenses is on the market only since July, and we really saw the jump. So I'm really glad that we can provide this, and I really hope that I know World Health Council of Optometry is already pledging for myopia, and I really invite everyone in our region to do the same, because one day or another, if it's not this year, it's going to be next year or the year after, you will have patients with high myopia, children 6 years old with -4, and you will have to find solutions because the impact of high myopia is huge.
Okay, thank you for that. There are a few questions from the chat asking for, is this myopic control lenses only for myopia or simple astigmatism, or can this be prescribed for the people with a higher astigmatism also?
So we have on the two lenses, you have stock lenses, which are from plano to -6 with a cylinder included of 2. So this is already made lenses and you can have them very fast. Otherwise, we have a range from 1.5, 1.59, and now 1.67 from plano to -9, included a cylinder up to 6. Okay, included.
Okay.
So it's on top of that. I know. I have many requests, even dailies, for children having higher myopia. And what I suggest is that when it's possible, not all the time, but when it's possible, to combine contact lens and myopia. So you do a piece of the refraction with contact lenses, and on top of that, you put myopia. This is the solution for that.
That's nice to know. Thank you.
Dr. Ajahn, I just want to ask you that what is your take on the undercorrection of myopia? We often tend to see the patients, children's being prescribed the undercorrection. Do you feel that is a good for myopia management or that is a wrong choice?
Undercorrection of myopia has been seen classically as a way to preserve the accommodation, not to progress myopia. Sadly, evidence has shown it does actually increase the progress of myopia. So please, I'm using this platform and whatever platform we will talk to kindly request practitioners to stop undercorrection of myopia. Simply think about it from an optical point of view. If you undercorrect myopia, there is still some optical blur. So it will actually trigger axial elongation because that image is not reaching the retina the way it should be. And what favor are you giving to the children for not letting them be able to see clearly, ethically as well? So both ethically, scientifically, and optically, it's not good at all. So we need to stop this and give them full optical correction, at least if we're not offering them peripheral defocus ophthalmic lenses. And this is the other thing we should do as well.
So do you do the peripheral refraction? Do you have any idea about peripheral refraction?
Well, we used to do that in the UK in the lab, and Alex can discuss that further. She remembers the days. And it is important, but how clinically easy it is to be done, how effective it is, and how the practitioner can translate it to the patients. If you stick with your proper objective and subjective refraction, to be honest with you, and include cycloplegic if possible, that's more than enough for your daily practice, in my opinion, unless any of my colleagues say otherwise.
So basically, in our clinical practice, we do peripheral refraction with the help of open field AR and with the help of PARC, and that is very easy. As we know that all the myopia control lenses talks about the peripheral defocus and they induce the myopic defocus. So we should know that what is the pattern of periphery. So I just want to ask Ms. Alma that you talked about the coordinate care model. So how do you take on the myopia patient and the model? So how can we implant that?
Okay, so I will have to first just remind that it depends where you are working on. So, for example, as I mentioned, in some countries like US, UK, where the optometrist can do everything, including prescribing atropine, um, they will not need very much of a collaboration with any ophthalmologist. But in all the other countries where the optometrist is limited to certain solutions, like they can only prescribe spectacle lenses or contact lenses, or even in cases where they can refract only children above 14, or for example, in Germany, under 14, you are not allowed to refract on children because you have to put the drops and you are not allowed by law. So considering these limitations, it is very clear that it's required a kind of collaboration. So sometimes parents send their children first to the ophthalmologist, where they get all the measurements there, and they get the prescription for the lenses that they have to use. And the optometrist prepares, like does the lens fitting and everything, and follow up after, like, I don't know how often it can be follow up. It depends on the solution that you give them. If it's spectacle lenses, contact lenses, or atropine, so it should be a regular follow up after that. And this also works with relationships. Sometimes parents will feel safer to stay to the ophthalmologist all the time, and this collaboration is going to be very difficult. However, even in a purely ophthalmology center, I would say, or practice, there are optometrists, because optometrists are the ones who cover all the assessments before bringing the patient to the ophthalmologist. So it doesn't matter if you are like in the same setting or if you are apart and you decide to collaborate, it will be a certain level of collaboration. You have to decide, and you have to make sure that you kind of make that very clear and very transparent so it works for both sides. And again, you keep always in mind the patient needs, what is important for the patient, what the patient is requires in that case.
Can I clarify two or three questions that I read
Yes,
on the
doctor.
chat? Yeah, one is, I don't know if I explained well myself about cycloplegia. If you have a patient that is aphakic or pseudophakic, there is no accommodation, there is no lens, so there is no cycloplegia. Okay, so in these kind of patients, we don't need to put the drops for cycloplegia. Although sometimes we put the drops to dilate the pupil, so we have a better light when we do the refraction using the retinoscopy. The other question that I had is about how often and which drops I use depending about the age. And I believe that the person that asked is coming from Africa. She's asking if there is a different protocol for Africa. I do believe that dark irises and dark skin colors are harder to the pupil to dilate and to relax also the ciliary muscle. Okay, so I remember when I was in the US some years ago, they started with an spray that they put on, telling the child to close their eyes and the child will dilate. I remember I brought that spray to Venezuela. In Venezuela, we're all mixed. So I used a spray. I didn't work in anyone. So it's the same thing that is happening in the Gulf region. So you need to do a good cycloplegia because most of us, we are with dark iris color, okay? Normally you do in less than 3 months, you use cyclomydril, 2 doses or 3 doses. If you think that that doesn't work, I add tropicamide 0.5%. In children that are less than 1 year, I use cyclo 0.5% and phenylephrine 2.2, 2.5, I'm sorry, phenylephrine 2.5. And if that is not enough, I add tropicamide. And in children that are older, I use cyclopentolate 1% with phenylephrine 2.5%. And normally that is enough. Okay, if I'm looking for cycloplegia, not only for dilation. And normally 2 doses, it is important to separate the doses at least 5 to 7 minutes, one to the other one. And I really recommend not to clean the eyes after you put the drops and to use a drop of proparcaine on any topical anesthetic before, because it will help you before the first dose, not in every dose, because it will help you to the absorption to the drops. And I'm sorry, I didn't want to interrupt you. Okay, I just wanted to answer that.
Thank you, Dr. Pedro. There's a question in the chat. It says, my child has a refractive error of minus 0.75, but a doctor in my country diagnosed latent hyperopia. The doctor recommended planar lenses with a plus 0.5 addition. Do you agree with this assessment?
If the child with full cycloplegia is minus 0.5, is not hyperop. So I think that it's something that is not right in the.
I think initially minus 0.75 was prescribed, and then a latent hyperopia was found and a small addition was given. So he wants to know whether this is acceptable or no.
No, I don't think he needs a full cycloplegia refraction, and then they will know what he has. And depending of the age, if he's a young child and he has minus 0.5, you don't need to correct it. But first you need to have the diagnosis correct.
Any other opinions from other speakers, please?
If I just may say, please, if there is one thing to remember in this webinar, and I know it's hard to do it, and I do understand, but it's the importance of cyclorefraction. And into myopia management cases, this is what we had many discussions with Dr. Yazan-Gamo, is really how cyclorefraction is important, at least once a year, in terms of myopia management, and not only with children. So this is just really what I would like. If there is one thing to remember, okay, myocare, please do, but as well, cyclorefraction.
Okay. Thank you, Celine. And there is one question for you, Celine. They wanted to know whether there's any link, how to dispense this myocare lenses in terms of fitting.
Very easy. It's a normal single vision lens. It's a spheric lens. So you need to take the PD and the height. Because it's an aspheric lens, you have two options by taking the height. The first one is to take it normally, okay? And then you remove 0.5 millimeter by degree of the pentoscopic angle of the frame, okay? But like any other aspherical lens. Otherwise, you put the head up so that it's going to be very, very straight, and you take the height that way. So it's even easier than a progressive lens. No problem of adaptation because you don't have an addition at the bottom of it. It's really just like any aspherical lens, PD and height.
PD and height. Okay. There is one question for Dr. Yazan. How to perform peripheral refraction in the clinic, especially in the myopia?
Can you repeat the question?
How to perform peripheral refraction in the myopia clinic setup, or basically in the clinic. They want to know how to measure this.
I'll probably let Dr. Alex answer that question. But let me be very honest with you. I've been hearing peripheral refraction over and over this evening. Trust me, from my humble experience, you don't have to really bother yourself at all with it. At least for day-to-day care routine for myopia management. Even in the International Myopia Institute guidelines, it's not recommended as a standard procedure at all. It's mainly for research purposes to monitor the progression and evaluation some of the efficacy, but for clinical reasons to monitor the progress of myopia management, you don't really need it at all. Kindly, please focus on your proper objective and subjective techniques. In the latest study that I've done, I haven't published the data yet. The scope of optometry practices in the region is way behind the international standards in terms of everything. So in terms of a proper delivery of prescription to the patients, a proper cycloplegic fraction at least once per year, taking proper PD measurement, even simple thing as a PD measurement and the frame height, we're not doing it at all. So let us focus, may I say that, on the basics of our bread and butter as optometrists. And I think we simply forgot the basic humble skill of retinoscopy. We should never underestimate the power of retinoscopy. Remember, autorefractors, desktop autorefractors can easily over myope a child by at least half a diopter. And we've seen the ongoing results from the study that Alex, Professor Barrett, and I did in Jordan. Many patients we thought who were emetro, they were not, right? When we did the cyclo auto. So this is something we need to bear. And talking about open field autorefractors, it was the bane of my PhD experience back in the day. I love it, but the fact is, you know how expensive it is? How many companies actually produce it? How accessible it is for practitioners to have it, and how difficult it is to use in a clinical setting. And actually, if you do not properly instruct the children how to use it, you will mess up with the results completely. And if you don't mind, I would like Dr. Alex actually to comment, whether you want or you don't want, Doctor.
Yes, doctor, please go ahead.
Thank you.
I mean, I absolutely agree that in terms of performing peripheral refraction, it's not a practice that's done in the UK. I think practitioners who work in myopia management focus very much on retinoscopy, cycloplegic retinoscopy, at the start of any treatment, and the measurement of axial length. I mean, from my PhD days, I remember how difficult it was just to try and get a measure of any level of visual acuity within the central 10 degrees of the fovea, just coming slightly off within the parafoveal areas. So trying to do a refraction, I think would probably not give us very reliable results. So I would support what Yazan said, is to focus on the skills that we have learned and use those to the best of our abilities.
Thank you, Dr. Alex. May I request all of you to just share one line or two on take-home message for all the participants? Each one of you to give a take-home message.
I will do.
Yes, yes.
Don't hear the patient. Don't give false expectations. Tell them truly what they're gonna go through in refractive errors. If you have a patient that is pseudophakic or aphakic, tell them that they're gonna use glasses all their life. They will always try to push you about it. If a patient has amblyopia and you need to treat the amblyopia, be honest about it, be firm, and be positive as well. Okay, this is one take.
Thank you. Dr. Yazan?
I'm not sure what to say after what Dr. Pedro has said, but I would like you to consider collaborative eye care with all the O's in the industry. Some of us are not allowed to do cyclo because of our scope of practice. So we need to have a friendly pediatric ophthalmologist to help us. Lots of us do not have enough skills to conduct binocular vision assessment and management. So if you don't want to brush up on your skills, a good orthoptist collaboration is quite important as well. And please, yearly cycle refraction and at least 6 months or a yearly optical biometer axial length measurement is necessity. Thank you.
Thank you. And Miss Celine?
Keep keep on education program, stay up to date about what is going. Myopia, whenever you're going to a congress, myopia is a big title. We have so many studies, we have so many combined studies now about myopia management, new technologies. We have so many different types of children possibilities. Stay update about what is going. This is really something. It's moving all the time, and yes. So because they already all said very nice things, so I have to find something. But this is really important. Just stay update, continue to follow studies, latest technologies, what is going on worldwide, here in US, in Asia, in Europe, in Africa, wherever. Just stay update about all refractive things. Actually, I'm talking a lot about myopia, of course, but all of it, continuous knowledge. Yeah.
Sure. Thank you, Celine. And Dr.
I will add, I will add just, I mean, everything was said, and I would just repeat if I would, say something related to my topic. But what I would like to say is that if you are not willing to brush clinical skills or to read papers all the time, do something that might change your life and the life of every person that is around you, that is adjust your communication to the level of the person that you have in front of you, be it a child, be it a parent or any patient, and be it your peers that you work together every day. Sometimes little adjustments can be life-changing also there, and it would serve for better work and for better relationships. And have a resolution plan, a conflict resolution plan. If things go bad, you need to know how to deal with that. So thank you very much.
Thank you, Dr. Alma. Dr. Alex?
I will be very brief because everybody has said such wonderful things. The retinoscope is your best clinical friend.
Okay. Thank you so much, speakers. I'm going to hand over the session to Mr. Swarna Kamal for the closing summary.
Here I would like to thank each one of you, or all the speakers, our beloved audience, and all the moderators. Without your support, this event will not be success. Here I would like to announce that your CME certificate and your certificate of attendance will be delivered to your email ID within 15 to 20 working days. Here also we would like to introduce our October 5 conference, which will be held on Millennium Plaza, Dubai on 11th and 12th October to mark the World Sight Day 2024. So what are you waiting for? This is the one and only optometry event happening in this country. And if you as an optometrist do not support us, who else? So I would request all the optometrists, ophthalmologists and orthoptists and all the eye care professionals to join this knowledge fest, which is accredited by around 16.59, so around 17 CME points in 2 days, and it has so many workshops and debate and so many other different kind of session, because our main motto is that to make this conference a unique conference in this region. We are not believing on only talk and only listen. We are collaborating with all the audience, where audience can enjoy, they can have chances to win so many prizes. There will be abstract competition winner, there will be mystery box winner, there will be October's passport is there, so many things. This beautiful conference, and we have done so much of background work. Just come and experience this one. I can guarantee you, this kind of unique conference you will never had in your life. So please join us in this conference, and here I am signing off. Thank you everyone. Over to you, Ms. Devakan.
Am I audible?
Yes, please carry on for vote of thanks.
Yes, yeah. Okay, thank you. On behalf of United Optometrists Forum, I would like to express a heartfelt gratitude to our esteemed speakers for sharing their valuable insights and expertise. Your knowledge has truly enlightened us and enriched today's session. We also extend a sincere thanks to all the participants for their active engagement and thoughtful questions. We hope this webinar was so informative and inspiring for you as it is for us. Your presence and participation were key to making the event more successful. Special thanks to Mr. Sujit Shaw for chairing the panel session, and a heartfelt thanks to the prestigious ZEISS Vision Care for providing the latest updates, making this event yet another milestones in the continuous medical education. And special thanks to Ms. Celine Cambrose and Mr. Budiman for their unwavering support and for consistently keeping the eye care practitioners informed on the latest advancements in myopia care and control. Wishing everyone continued success in your respective endeavors. Thank you all once again.
Thank you very much.
Thank you.
See you next time for part 2.
Thank you.
Definitely, yes.
Bye-bye.